Welcome back, everyone, to the second TiCME Chat. And as promised, I've got Dr. Dave Lamond back again, retrieval and emergency physician, to answer your questions from the first talk. Should you treat traumatic hypotension?
Hey Nick, it's good to be here.
So Dave, the take-home messages for the first talk were one, that your 9-year-old thinks you don't have a voice for radio. 2, that radial and other pulses are unreliable at estimating systolic blood pressure. 3, that if your systolic blood pressure is less than 110, you have an increased risk of death. And 4, systolic blood pressure is a very late marker of how unwell you are in trauma.
Great summary, Nick.
Alright, so let's pull things back to this case that we talked about last time. We've got this young bloke, he's had this horrible car accident, you put him in the back of the chopper, systolic blood pressure's 80. Are we going to treat it? Is there any evidence?
Good question, and that's what we're going to have lots of debate about. Nick, this is the lethal triad that we're trying to avoid in trauma. So the combination of acidosis, hypothermia, and coagulopathy. And essentially, our goals of our treatment are to try and prevent each arm of this triangle.
Okay, and so obviously the patient who's decompensated in shock, who's getting that high base excess we saw from last time, is already in the middle of this triangle, is that right?
Yeah, so they've got predominant acidosis and they're probably developing their trauma-related coagulopathy. And if we're not careful in this sort of environmental situation, they're becoming hypothermic.
So this whole, concept of resuscitating trauma patients is called damage control resuscitation, and it's got 4 main arms: delayed resuscitation and permissive hypotension, and they're all part of what's called hypotensive resuscitation. Then we've got the concept of hemostatic resuscitation, and then finally damage control surgery.
So delayed resuscitation. So this is where you're not providing any fluid therapy until you've got definitive control of the exsanguination or the bleeding source. It may make sense when your blood pressure is controlled, but not if you're in decompensated shock. Once you start to treat the blood pressure, then that's the permissive hypotensive strategy.
So delayed resuscitation only really makes sense when you've got really short times between the injury and the definitive source control. Is that fair enough?
That's correct. You're trying to avoid that slide into decompensated shock.
So permissive hypotension, therefore, is when you resuscitate to a predetermined blood pressure that's a lower set point than what would be normal for that patient. And as we said last time, the pre-hospital guidelines will often say just resuscitate and get a radial pulse. In the NICE guidelines from the UK, they actually say central pulse, which we saw last time could be really, really low. Hospital guidelines suggest a systolic of 70 to 90, some up to 100, and other authors who are quite prominent suggest, without really much evidence for this, that a MAP target may be better of 60 to 65.
So hemostatic resuscitation, so you're trying to replace whole blood with whole blood. Now the aim for this is to reduce coagulopathy and you avoid diluting the plasma with large volumes of crystalloid. Whole blood would be the best product to use, but in most of our trauma settings we're relying on blood components to do this.
So this first cab off the rank for damage control resuscitation is permissive hypotension. Let's have a bit of a chat now to find out if there's any evidence for it. So this is the study, Dave, that everyone talks about when they talk about permissive hypotension. This is Bickle, good study, but is it applicable to us?
I think it's an important study to recognise. It was penetrating trauma in patients who had either received no resuscitation pre-hospitally or in the ED versus patients that got pre-hospital fluid. The essential mortality survival was 8% better in the group that got delayed resuscitation. However, saying this, both groups in the OT got 7 litres of crystalloid and 2 litres of blood. The other important thing is the time from injury to presentation was very quick. So it was about 30 minutes, and the time in ED was about 45 minutes to the definitive control. So probably for our Australian demographic, it's probably not representative of what we see here.
And basically, in the treatment group, they got about 2.5 litres on average of crystalloid versus about 400 mils in the non-treatment group before they went to theatre. Is that right?
That's right, yeah.
So what we're really looking in this study is the difference between giving about 2 litres of crystalloid prior to theatre. Everything else is about the same. Is that right?
That's correct.
Second study is Dutton, Journal of Trauma 2002, blunt and penetrating trauma this time, Dave.
Yeah, that's right. So this was a mixed group of patients that had at least one systolic blood pressure less than 90 pre-hospitally. Once they arrived to hospital, they were randomised to groups to either get target systolic blood pressure greater than 100 or 70. There was only 110 patients in the study, so 55 in each group. The interesting thing is that there was no overall difference in mortality between the two groups. One of the problems was that there was fluids given to patients in the pre-anaesthetic bay outside the study protocol. The overall death rate was quite low in this. There was 4 in each group. And I think as a total sample size, it probably lacks power in that respect.
And the interesting thing about this study and the previous study is that despite aiming for a low blood pressure and leaving it there, the patients themselves self-treated in essence, and they never actually compared two groups with very low blood pressure.
Yeah, that's right. So they were hoping for 100 or 70 as a systolic blood pressure, but in the reality, when they looked at the data, they had 114 versus 100.
Right, at TiCME we like to be very up to date. Here's a very recent study which is helpful to this debate, David. Carrick, Journal of Trauma Acute Care Surgery, 2016. Interesting background to this publication.
Yeah, so these were younger patients, 14 to 45 years, who had penetrating injury that either needed laparotomy or thoracotomy. In 2011, they published preliminary results which were positive, showing a benefit from hypotensive resuscitation. However, they finally published this year, or just in the last month, saying that there was no difference in mortality or secondary outcomes because they'd had to abandon the trial because of futility and failure to recruit the number of patients that they required.
And yet again, even though they were trying to compare the difference between a map of 65 and a map of 50, they actually got 65 in their low map group and 69 in their high map group. So really not really comparing the difference between subset of patients at all there, are they?
No, and I think this was highlighting again the problem of targeting specific maps in hypotensive patients that you're resuscitating. Yeah.
An oldie but a goodie, I guess, Dave. Mapstone's review of all the animal trials in 2003 is another oft-quoted study. What do you reckon?
Yeah, I like the conclusion, really. If you don't give fluid in severe bleeding, there's a much higher risk of death. I think that's a clear message based on what we're talking about in decompensated shock for our patients. The thing to recognise, though, that uncontrolled bleeding models in animals are usually a penetrating model. It's a disruption to a vessel. They're very heterogeneous groups in terms of what you're studying, and the follow-up is very, very short. So application to humans is hard. The relative risk was 0.37 of death for hyposensitive strategies in less severe bleeding. So there is some suggestion that in less severe bleeding, hypotension may be of benefit.
And they were only using crystalloid. We don't really know the delay times because they're not really quoted in these studies. And I guess the other thing is these are rats, and these are pigs, and these are dogs, and they had their tails cut off, or they were stabbed in the liver, or they had their aortas sectioned. I mean, is that really relevant to our trauma patients at all?
No, certainly not for us. We don't treat that many animals in our ED.
So still on the animal theme, Dave, there isn't very much data at all about how long a permissive hypotension strategy is going to be successful.
Yeah, this is a great study looking at a model of a blast injury plus a hypovolemic injury. So these were pigs that were subject to blast and then had a 30% blood volume loss. One group was resuscitated back to a normal blood pressure, the other group had permissive hypotension. All the pigs that were resuscitated to a normal blood pressure survived to 8 hours post it. With the permissive strategy, none survived past 4 hours.
So although animal models show that up to an hour and a half of permissive hypotension is okay, this one shows that once you prolong it, you may get high mortality. And for those of you who like Cochrane, this is the third and most recent update from 2014 of the literature for fluid timing and volume in patients with bleeding by Kwan et al. They weren't able to do a meta-analysis because the studies were too heterogeneous, and he found there is no evidence for or against the use of early or larger fluid volumes, and as usual for Cochrane, the summary is we need more and better studies. Righto, Davo, so to summarise what we know about permissive hypotension from the evidence.
Yeah, so there's good randomised control evidence in vascular animal models for penetrating trauma that delayed or permissive hypotension probably improves survival and reduces the need for blood product. However, there's weak evidence in humans that mortality is improved in penetrating trauma. For blunt trauma, the jury is still out. And it's unclear in brain injury at this stage whether permissive hypotension has any benefits over targeting a higher blood pressure.
So far we don't really know what to do about the timing or volume of fluids, but do we know what sort of fluid should we use?
So non-blood fluids, the choice is easy. There's no evidence to support which non-blood product to use. So in our service we certainly use simple crystalloid, either Hartmann's or normal saline. There is clear evidence that everyone agree that large volumes of non-blood fluid cause problems. They dilute you, so you become more coagulopathic. You can lead to abdominal compartment syndrome, you get fluid leak in other tissues, so ARDS, and you cause clot disruption. That theory of blowing off the clot.
So just to provide a little bit of number to what we just said, look, this is a big observational study from Germany. They've looked at a large trauma registry. They've tried to get about 1,300 matched pairs, and they matched them for 3 groups of blood pressure as well as injury severity scores, and they looked at low volumes of fluid given and high volumes, which they defined as less than 1,500 or more than 2,000 mils. Essentially, the mortality was the same with these groups. The blood pressures were the same between the 2 groups, but they gave more red cells in the high volume group, and these ones had lower hemoglobins. I wonder whether this could just be an effect of diluting the hemoglobin with pre-hospital crystalloid, which meant that their hemoglobin is measured lower, so people were more likely to transfuse them, and there is no way to tell why people got more volume from the study. And there was also a little bit more coagulopathy in the high volume group, as well as higher sepsis and organ failure in ICU later, but not higher death. Right, so reducing crystalloid volumes is important. We want to get into this concept of hemostatic resuscitation. It's very topical at the moment, and there's been a lot of armed conflicts around the world in the last 10 to 15 years. The only upside really is we've been getting lots of data on hemostatic resuscitation.
Yeah, so Borgman published in 2007 basically looking at high versus low ratio of plasma to red blood cells, and a ratio of 1 to 1.4 was shown to have a 46% mortality benefit in that group. That spurned a lot of interest in this ratio. Further studies went on to look at a 1 to 1 to 1 ratio of plasma to red blood cells to platelets. Since then, there's been more data looking at different ratios of 1 to 1 to 2, 1 to 1 to 3. Overall, none of them has shown a particular survival benefit over others. And I think that comes back to our principle is that approximating whole blood in terms of resuscitation is important. These are not the only factors in doing it, and I think as an institution, a massive transfusion protocol is the important way to drive for different plasma ratios. However, there's other things we need to consider as well. So tranexamic acid, the use of cryoprecipitate, and replacing calcium as appropriate.
So hemostatic resuscitation encompasses basically giving what you consider to be equivalent of whole blood, and that might be dependent on your resources available at your institution. When you do it, it's probably important to do it as part of an overall strategy that includes frequent blood monitoring, looking at fibrinogen, calcium levels, pHs, etc., and making it all fit together as part of a whole.
Nick, I'd like to take you back to the set of obs from our first chat.
Yeah.
So this is our critically unwell 21-year-old male that's trapped in the car. The numbers in red brackets are the time since injury. So the first important thing to note is this represents a substantially greater time than what we've been talking about in these studies in terms of resuscitation length. The other thing to note is that this patient was receiving small volumes of crystalloid, maintaining hypotensive resuscitation. You can see that the doctor was targeting a systolic blood pressure of around about 90, and the maps were up around about 70 to 80. What we need to remember about this patient is this patient had a PEA arrest when they arrived, essentially from hypovolemia. And as we talked about before, he was in the critical phases of shock, then had the terminal phase of shock with that massive catecholamine surge.
And was it true, Dave, that after he was successfully resuscitated, imaging, etc., did not find a major truncal bleeding source?
That's correct. It was all peripheral injuries, blood loss from peripheral injuries. So what did we get wrong?
So it's not really so much as what did we get wrong, but really how difficult it is in the pre-hospital and even emergency department environment to know what you're dealing with and to target the appropriate response. In all of the studies of the bleeding pigs and rats, you know what the problem is, don't you, Dave? You've cut their tail off, you've stabbed them in the liver. And for penetrating trauma, the knife's poking out of the chest. With this guy, we're essentially attempting to use a strategy based on an assumption that due to his blood pressure he must be bleeding from a large organ.
Exactly, and that getting him to definitive control and not resuscitating him aggressively till we get there is the appropriate thing. But in this case, we're demonstrating that in peripheral injuries with multiple bleeding sources that don't need one single source of control, this patient actually needed aggressive normalisation of his physiology to restore his circulating blood volume earlier than what he received.
So these entire arguments we're having, Dave, about fluid volume, types and blood pressures are really less important than identifying the patient who needs to have definitive source control early.
Exactly, and operating theatre should be part of that resuscitation, and your time in the theatre is also part of that time. So you damage control resuscitation where you're minimising that time where your physiology is abnormal, where you are shocked.
So I guess the principles of damage control surgery are that we're just going to do the minimum possible to stem the bleeding and then get the patient out and warmed into the ICU and try and bring them back later to fix up all the little bits. So at the end of this discussion, Dave, I think we've probably raised more questions than we have provided answers, but let's just see if you can put it all together for us.
All right, Nick, well, I'm happy to give it a try. I think the really important principle is that as identifying and looking at these patients, you shouldn't arrive with a predetermined idea of what you're going to do for this patient, that you're either going to hypotensive resuscitate them or not. It's much more complex than that. It's about their mechanism of injury, it's their underlying physiology, it's their comorbidities, it's the individual patient. If clearly a patient has a source of bleeding that needs embolic or operative control, then hypotensively resuscitating them until they can receive that is probably appropriate, as long as you don't run them into the critical phase of shock or the terminal phase of shock. If they've got multiple sources of bleeding without any needing definitive control, operative control, then you should be resuscitating them to end organ perfusion. So mentation, their urine output, their lactate, their base excess, and you should be using a hemostatic strategy to achieve that rather than large volumes of crystalloid.
So increasingly, Dr. Lamond, when we talk about novel strategies, new therapies, fancy treatments, we end up coming to the conclusion that in the end, it's best to let the human body do its thing up until the point where it loses control and falls in a heap, and then we've got to intervene. And that's your concept of normiostasis.
That's right. Returning everything to normiostasis is the best strategy.
Once again, thank you so much for listening to TiCME Chat. And remember, there is lots more critical care free education available on www.ticme.com.au.